Welcome, everyone. My name is Jackie Waldberger with Belmont Village Senior Living. In affiliation with our partners at UC Berkeley, it is our honor to host Dr. Louise Darrinson and to include our residents, ourselves, and you, the public, in our commitment to lifelong learning. If you would like to learn more about Belmont Village, I invite you to stay on the call after the presentation. Today we have 1,000 participants. Please use the Q&A feature for questions that will be answered after the presentation. If we are unable to address your questions, please feel free to email me at the address provided on your invitation. Before we introduce Dr. Aronson, I'd like to introduce to you someone very special, a Harvard graduate herself and successful founder and CEO of our innovative company, Patricia Will. Patricia.
Thank you, Jackie. It's indeed a pleasure to be here today. I think that one of the things that we've learned last year is how to take our commitment to lifelong learning to this extraordinary virtual level and touch so many of you with the wisdom that Dr. Aronson is about to share. I can't think of any better partner in our quest for lifelong learning than the partnership that we've enjoyed with UC Berkeley. Since the advent of our community on Berkeley land, built in affiliation with Berkeley, where Jackie works, our partner has been none other than Carrie Sweeney. Carrie runs the most innovative retirement center that we've ever seen at a university. And through the many faculty members and emeriti that live with us in our building and that Carrie comes into contact with, we've been able to extend our reach beyond that building across the country. Carrie, you have been an extraordinary partner since we began this adventure in the earlier part of last decade. You don't look a day older, and it's my privilege to introduce you now.
Oh, thank you for that very warm and welcome, Patricia. It's a pleasure to work with Belmont. This collaboration nationally has been very exciting. As you said, we get to extend our reach beyond just Albany and Berkeley. And we really enjoy being a dedicated partner in creating learning and creative opportunities for our UC retirees locally. So thank you for that. I encourage you, the audience, to join in afterwards after Dr. Aronson's presentation to learn more about the creative and evidence-based ways that Belmont Village is caring for those living in their communities. I do have the pleasure of introducing Dr. Louise Darrinson. I'm very excited that she can join us here today. She's a leading geriatrician, a writer, a professor of medicine at UCSF, UC San Francisco, for those of you all across the country, and author of the New York Times bestseller, Elderhood, Redefining Aging, Transforming Medicine, and Reimagining Life. So look for the paperback edition. It's actually coming out next week, we just learned. But furthermore, Dr. Aronson, I wanted to say, graduated from Harvard Medical School, and she received her BA from Brown in anthropology, medical anthropology. She's the winner of multiple awards, but she's also a beloved physician by her patients, a beloved professor by her students, and I can attest, a beloved by her staff. I worked with Louise for several years at UCSF, and was inspired and enjoyed the enthusiasm. Everything I learned about geriatric education, I learned from Louise Darrinson. So it's such a pleasure to come full circle and bring her here today to join you in sharing her wisdom from her book. So I will hand it over to you, Louise.
Terrific. Thank you, Carrie. Thank you all. It's a pleasure to be here. And I should say that one of the wonderful things that sometimes happens is when you watch someone you work with sort of take off, and that's what Carrie has done, leading this center so incredibly. And it's just, you know, ongoing pleasure to watch that happen to someone as talented and deserving as you. So thank you for inviting me here. So I think what we planned was that I will talk for a while and then we'll try and answer as many of your questions as we can. I'm going to introduce sort of this concept of elderhood. I also should say I've been deployed with the San Francisco Department of Public Health and the state since late April. But I'm going to try to steer clear of pandemic, though I will say that everything I touch upon here has showed itself to be true in pandemic, so you may notice things. What I want to start with is a question. What age is old? And for some people, this seems like a silly question, but it actually really varies. So there was an article in the New York Times a few years ago about a relaxation retreat for older workers in Silicon Valley. The age cutoff, you had to be to get there, you had to be old, so you had to be 30 or older. Right. Meanwhile, I have given talks at places with lots of older people, and I've had them raise their hands for different numbers, and we get to 85 sometimes, and 90 and 95 and 100, and some people still aren't raising their hands, and there's a lot of laughing. You may have an idea of what old age means to you, and you may also have the sense that maybe it means different things to different people. It turns out the Pew Research Center has done some research on this. But before I show you their results, I want to show you this picture in the upper corner. And what you see here, obviously, is a man in bed. And I show this to my medical students and I say, what do you see? And they say, oh, well, the patient's doing okay. He's sitting up a bit. He's got his pills there. He seems to be eating. That's really good. And then I tell them that actually this isn't a patient. What this is the great writer Isaac Bashevis Singer, some 12 years before his death. And in that time, he won the Nobel Prize for Literature and published 14 books, some for children, some for adults, some fiction, some nonfiction. So I think so often people look at people and all they see is old, and they miss all the things that make a person. And obviously, probably none of us did. Nevertheless, with work and our age. Research center, young you are, the younger you consider old beginning. The older you consider it beginning. Just to show the way in which our sociocultural experiences influence this. They also looked at what age men and women become old, and both genders, sorry for being binary here, but both genders said that men become old at 70. But when asked about women, men said women become old at 68, and women said they become old at 75. So you see how who you are determines what you think of as old quite commonly. Now, prior to the pandemic, there was work by a professor at Stanford, he's actually an economist, that suggested that maybe old was getting older. So if you consider middle age the point at which about 1% of the population dies, and being elderly the point at which 4% of the population dies each year, then it looked like if you compared 1920 to 2020, we were actually getting old decades later, and that's consistent with longevity. On the other hand, there's been pandemic. This is my one real pandemic slide, which has shown us that age does matter. 81% of deaths in San Francisco, it's 89% of deaths have been in people age 65 and older. Now, the majority of people age 65 and older who got COVID did not die, but there was an increased risk, and the risk increased with each advancing decade, actually starting at age 45. So aging is real, it makes a difference. And on the third hand, I'm running out of hands here, part of why the death rate was so high was our ageist society and our ageist healthcare system. Many deaths happened in congregate settings that were inadequately funded and equipped to deal with this crisis. And some happened in other places because we often study what happens to adults and then apply those results to elders. So we say older people are different, so we're not going to include them in the trial. Then we get the results and we apply the trial results to those older people, even though we already established they were different. And so not surprisingly, their results are sometimes different. I was asked to have some learning objectives. So mine are really just to talk about what the language we use, how we even talk about old age actually makes it worse for all of us. I want us to think about elderhood in relation to childhood and adulthood, because we actually don't have to reinvent the wheel. There are precedents. What we do have to do is do the same thing for elderhood that we already do for childhood and adulthood, and then recognize some opportunities where we can make things better for all of us. So, starting with redefining aging. I have a blank slide here because I just want you to think of, if you are old, what are the words you like to be described with that describe your age? And if you're not old, which are the ones you prefer and that you can imagine applying to yourself one day? When we talk about old age, we tend to tell a few stories. One of them is that as a good American, you can eat your kale and blueberries and you don't have to grow old. Now, I have bad news because I've been a geriatrician for over 25 years now, and we have to grow old and die. Actually, growing old is a good outcome. Some people die young, and that is far worse. There are many wonderful things about aging, indeed. People are happier, and we'll show you that too. But this notion that these things can keep you from getting old is not true. What they can do is keep you healthier as you grow old, and that also matters. There's also stories of the exceptional elder. So, do your abs look like his? Can you do the splits the way she is? I personally would require orthopedic surgery if I tried to do what she's doing. Exceptional people are by definition exceptional. When we hold the rest of us to that standard, we make everybody feel like failures, which makes them stop trying. We can all age better. Almost all of us can age better than we are, but not if we're held up to a standard that we may simply genetically or socioculturally be not prepared to meet. And last but not least, the silver tsunami, that the aging of society is a disaster that's going to bring ruin upon everyone. This is a bald-faced lie. There is no upside to tsunami. There are many, many upsides to aging and having an older population. That we recognize so few of them and that we take advantage of so few opportunities of old age is not a biological problem. It's a social challenge. There is also this, of course, the American Geriatric Society, of which I'm a member, so physicians who specialize in aging, is maybe 7,000 people strong. There is something called the American Academy of Anti-Aging Medicine, no training required, which has 25,000 members or something. And think about, the American Academy of Anti-Woman medicine, the American Academy of Anti-Child Medicine. I mean, children cost so much money. They can't take care of themselves. I mean, it's terrible. And yet we don't have an anti-child medicine establishment. When you have anti-age, you have anti-old people. You cannot have it both ways. And I think we all know that age isn't just a number. I think you reach your mid-40s or so, and it's pretty clear that there's more than that. We also tend to have a single standard for beauty, which pulls most of us out of that picture. So what I hope to convince you of today is that a lot of this is a matter of how we look at things. So John Berger wrote a book about this, and there was also a television show in the 70s, and it's still incredibly apt. So look at this picture. It's beautiful, right? It's those big lines, like what he's doing with color. You see a path, into nature, which for those of us who've been locked up for a year looks gorgeous. But you might look at this really differently if I were to tell you that Van Gogh, the artist, this was his last painting before he committed suicide. Now we see the birds circling. Now we see the darker lines. Now we look at this maybe a little bit differently. Similarly, when we look at an old person, we often see this woman, her head bent, as a doctor, I think, is that osteoporosis? Is she depressed? She's by herself. She's probably widowed. That happens to most women once they reach a certain age. But what happens if I show you a contemporaneous, so picture taken at the same time, picture of the same person? It was Ruth Bader Ginsburg. And she actually wasn't alone. She had her Secret Service detail. So what we see depends a lot on what we're told before we look, and a lot about what else is in the frame. That happens all the time with aging. For instance, we're almost never shown these curves. This is what's called the U-shaped curve of happiness, which is taken from most countries internationally, the exceptions being the very poorest of countries. But what this shows is that people actually tend to become happier as they move into their 60s and beyond. They also become less anxious, and consequently, their life satisfaction goes up. We don't hear this story, do we? Look for it, try and find it. Do you tell it yourself? Yes, old age comes with limitations and disappointments, but it also comes with some real opportunities for doing things that matter most, for prioritizing differently, some would argue better, for time that things that matter when you're not juggling kids and jobs. But people don't tend to believe these stories when they're told them. So this was an article from a couple years ago by Judy Graham, who's a fabulous old age reporter, works a lot for Kaiser Health News, among other pubs. So she published this article on why so many older Americans rate their health as good or even excellent. And what she tweeted was that her first responses on Facebook were denial, denial, denial. Now, it wasn't that the average 70-year-old or 80-year-old or 90-year-old was saying, oh yeah, my health is just as it was at 30. They weren't saying that. What they were saying, and this is part of the U-shaped curve of happiness, they were saying, given my age, given how I want to be spending my time, my health is good enough or even excellent. They were doing what I call the 3 A's. One is accepting the difference of age. Number 2 is adjusting or adapting to those differences. And number 3 is taking action to ensure that you have the same pleasures and activities, maybe in different form, that have always mattered to you. So that's why they rated their health as good or excellent. Meanwhile, sometimes the people who are supposed to be part of the solution are part of the problem. This from my own people at the American Geriatric Society, but also this is a standard in medical publications that you're only allowed to use the words older adult for old people. So what this says is words like aged or the aged, elder or elders, elderly or the elderly, and seniors should not be used because they connote discrimination and certain negative stereotypes. I would say that this is shooting the messenger and not the problem. What is the real problem? When we call a kid a teen or tween or child or toddler or infant, when we call a young adult, when we call an adult, when we call a middle-aged person middle-aged, do they call that discriminatory? No, they call that an accurate description of where you are chronologically in the normal human lifespan, but all the words for old age are considered not okay. And indeed, the favorite thing is this sort of misleading euphemism. Older is relative, right? Older just means you're older. So an 11-year-old is older than an 8-year-old. At some point, we are frankly old, and that needs to be okay. And then we use the word adult because it's okay to be an adult, and it's not okay to be an elder. That makes it still not okay to be an elder. The more we use these terms that undermine old age, the more old age gets disrespected and doesn't get the services that it deserves equivalent to those of childhood and adulthood. Another example of ageist anti-ageism, in my opinion. So this was from a big project from the city of Boston to try and go against, to try and change the story about aging. So here's this stunning woman, more beautiful at 86 than I was at 16 or 26 or whatever the normal standards are. And she says she's a lot of things, but she's not over the hill. Well, in science, we use curves in math as well, and they're usually an arc, and the midpoint is the peak of the arc. So anybody over the midpoint is over the hill. She's over the hill. I'm over the hill. Most of us are over the hill by 35, 40, 45, at least by 50. The problem isn't being over the hill. The problem is the notion that once we are over the hill, we are human beings of lesser value. Similarly, from this campaign, this man, Vinny, age 83, says, I'm a longtime boxer. I can still pack a punch. I'm many things, but frail isn't one of them. a fact of human life, and I'm not saying anybody has to like this, but if we live long enough, we will become frail. And when a man who is 83 says, I'm what many things but not frail, he is creating a world in which when he becomes frail, we can discount him. Because right now what he's saying is his value is because he's not frail. I think his value is because he's a human being. So I prefer this from the great writer Ursula K. Le Guin, who died, I think maybe 2 years ago now. Pandemic mind, sorry. She had some fantastic comments in one of her later books, including, to tell me my old age doesn't exist is to tell me I don't exist. I mean, look at her. She was obviously an older woman in these photographs. And to deny that was really to deny a core part of her identity, certainly not her only identity, but an essential defining trait. And then I love this. If I'm 90 and believe I'm 45, I'm headed for a very bad time trying to get out of the bathtub. So true. Age matters. So now I'm going to touch kind of briefly on medicine. Medicine and old age have been particularly pertinent in this year of pandemic. And is it all medicine's fault? No. But what is happening in medicine reflects what's happening in society. And when we improve one, we improve the other. So when I was a medical student, actually, in this very auditorium, we learned about two flavors of people, children and adults. We also pretty much learned about males and about whites. When a person wasn't male or white, they were pregnant or they had sickle cell disease. And our rotations are pretty much the same rotations we had back then. So you have pediatrics, you have family medicine, which shows younger families, people in the procreating years. I will say as a geriatrician, often the daughters of my children are postmenopausal. So they are not included in this picture. And then we have obstetrics and gynecology. Now, gynecology women may need their whole lives, but obstetric is limited to a very small portion of our lives. So there's a whole rotation on that, but there's nothing about old people. And most clinicians will treat older people through most of their careers, but fewer than 2% will do anything about delivering a baby after they're trained. Meanwhile, the NIH has had research inclusion mandates for women and minorities starting in the 1980s and for children starting in the 1990s, but it was 2019 before they mandated inclusion of older people in trials. Now that has come to benefit. The trials for COVID treatments and vaccines have been imperfect in terms of older adults, but most have at least included some. So I'm very happy to report that we are making progress on that score. We're not there yet, but frankly, women, people of color, and children aren't there yet either. There has always been a problem in how we report data. And this is actually something where I do believe COVID has made a big difference. Now, this is the kind of chart we want to see. This is adverse drug events. So let's say over-the-counter medicines. You'll note that they have warning for kids, they have warnings for pregnant women, and they often have warnings for particular diseases. By far, the people harmed by over-the-counter drugs are older people, and by other drugs as well, because they weren't included in the trials. And you can see how at the lower graph here is the people in their 60s, then higher still is people in their 70s, and highest of all is people over age 80. So you really need to break these things down. But in most of medicine, it has looked more like this, where we have subcategories and we lump all old people into a single category. That makes it really hard to make policy or clinical practice or anything else that respects the differences of different people at different ages. We have seen this from the CDC for years. Actually, I think this is 2019. I should have updated it to 2020 or 2021 even. This is the vaccine schedule, and you're not supposed to read this, but what it shows you is that for children through age 18, they have 17 different subschedules based on changing biology and social behaviors. What they have for adults is 5 schedules. So basically 4 for people between the ages of 19 and 64, and 1 for people over age 65. So my oldest patient was 111. So are you telling me that in a half century of life, there were no physiological or social changes or behavioral changes in people's lives? That's simply inaccurate. I am hoping COVID will change this because they are breaking down into decades. Flu is something often compared to COVID. And here are some quotes, again, from a couple years ago, talking about flu. This is from a major publication that talks about medicine, health, biotech. Hospitalizations due to flu are also on the rise, with the highest rates among kids under age 4 and older adults. Last week, the CDC reported that 4 more children have died from flu this season, bringing the total number of pediatric deaths to 11. Now, were young kids at higher risk? They were. But at this point, the older adults who had died from flu were into the tens of thousands, and there weren't numbers. Why weren't there numbers, right? Are 11 kids worth, say, 11,000 older adults? Of course you don't want children to die. If we're all going to die, right? Mortality holding steady at 100%, the best time to do it is in old age. But that doesn't mean those people didn't die prematurely if they got the flu, and that's what killed them. And their deaths should count, but sometimes we don't get those numbers. Why? So this is from the San Francisco Chronicle. In California, the public health department used to require counties to report all flu deaths among anyone under age 65. Though people 65 and older are the most vulnerable to flu, reporting their deaths is problematic for 2 reasons. One, it required too much time and money, right? So older people aren't worth the time and money that other people are. And their cases are often complicated by multiple health problems. So this is an excuse often used about older people. Oh, there's so much going on. I don't know what the problem was. But let's say you have high blood pressure, your thyroid doesn't work well, you have some arthritis, maybe you have a little heart failure, it's well controlled, or something like that. You're doing just fine. You get the flu and you die. I think we can safely say that the flu was at least a major contributor to your death. It's just not that complicated. And yet we pay less attention to older people. So this is the CDC's COVID page. I did add this one in, I forgot about it. And this is the public facing page, although actually the one for providers is quite similar. So it talks about things you need to know. What are the symptoms of COVID? What about testing, vaccines, preventing getting sick if you are sick, people at increased risk, daily activities, travel. Oh, look, there's a whole subsection for children and teens. And indeed, that subsection pulls out to 9 other sections with subsections. Interesting, because it turns out that if you use people age 18 to 29 as your standard, children are between 9 and 16 times less likely to die of COVID. But older people, from 200 to 630 times more likely to die. But do you see on this list older adults? No, you don't. They are there, they're hidden. They're hidden under people at increased risk. And then they get 2 subcategories. Can you imagine a condition that affected children or adults where so disproportionately, right, 81% of deaths nationally, where there was much less information on the category of citizen who was hugely disproportionately affected by the illness, right? It wouldn't be allowed. And yet here it is, a year into pandemic. This is how this looks locally, state levels, nationally. This leads to doctors like that, not this one pictured, but a young doctor I worked with some years ago who talked about a call night and saying he'd staved off, you know, he got a sign out about a person who was dying and he figured it was another little old lady, so he saved it to the end. And then he felt really badly when it turned out to be a young woman. He said that without shame, without any sense of what he just said, which meant that the old woman didn't count, but the young woman's death did. And again, of course, we'd rather die old, but that doesn't mean it doesn't matter. Now, this book, Why Survive, by Robert Butler. So Bob Butler started the National Institutes on Aging. He started the first division of geriatrics in this country. He coined the term ageism, and he won the Pulitzer Prize for this book in 1975. And what he said was, the tragedy of old age is not the fact that each of us must grow old and die, but that the process of doing so has been made unnecessarily and at times excruciatingly painful, humiliating, debilitating, and isolating. I agree with him completely all these years later. And now is the moment to make a difference. Indeed, we have already seen a difference happening, because when I became a geriatrician, I would see almost nothing in the lay press about aging. And maybe 10, 15 years ago, I started seeing it more often, and now I literally can't keep up. So we can make this change together. How do we reimagine life? Well, I think it starts by making sure that people know that old age isn't just this tunnel of dark, dismal, medicalized rooms leading to, the famous bright light at the end of the tunnel. Elderhood is a long and complex life stage. Childhood lasts we say, 2 decades, give or take, right? We all know people who fall into different categories. Then we have adulthood, which lasts, 30, 40 years. It actually varies a lot. When you get into elderhood, depends a lot on how hard your life has been, how healthy you've been, how much social advantage or disadvantage you have. And then elderhood, which also lasts many decades for most of us, and as long as childhood for anyone who makes it there. Now, when thinking about elderhood, I think it's good to take a page from the history of computers. When I was in college in the 80s, there was one computer. It took up an enormous city block. Only the engineers used it, and it was sort of dweeby looking, guys like this. And, there were these terminals the rest of us could use. And sometimes, then eventually we got these sort of desktops. And still it was mostly, people dealing with numbers who dealt with them. And then this guy came along, Steve Jobs, who had his failings admittedly, but he said, hey, look, if this thing is so good, why can't we make it of use to all people of all backgrounds, people who do all sorts of things? And also, just because it's functional, does it have to be ugly? And he's proven that, of course, it did not. The same is true of old age. So these are some photographs. I apologize for the people calling in of, a bathroom where you basically have to, climb into the tub at great risk, a doorknob that's hard to turn as hands get arthritic, and a very steep stairway into a theater. But theaters don't have to have stairs at all. And doorknobs can be made to be used. We all learned this in COVID too, right? You could use your elbow, you could use your sleeve. And bathrooms can be sexy and safe simultaneously. These, when I used to do live talks, I like to show these and have people guess what they are. These are actually hearing aids. They look like cufflinks or cool pieces of jewelry. And then why does clothing for older people have to be kind of ugly? Can't it be stylish and still fit older bodies, which absolutely do change in shape to a degree I didn't realize actually until I went shopping with my mother as she moved through her 80s. We see the same thing in parks, right? Places for kids, places for adults. Increasingly, we do see places for older adults, like pickleball, where you don't have to run as far, but you can still be outside doing all the wonderful things that exercise does. It's social. You've got fresh air. You're moving around. Fantastic. And we can put places in parks. People doing Tai Chi often have to bring their own towel. Why wouldn't we create a park that enabled people to do Tai Chi or Qigong, which are proven to lower the rates of falls in older adults and actually move you through the functional movements that enable you to be independent longer? And places are starting to put up things for older adults, but not nearly to the rate they do it for kids or adults. So I will just refer you to the 11 domains of livability for age-friendly cities. Argue for each and every one of these in your community. Each area of our society fails to address elders as well as it addresses kids and adults. I'm also just briefly going to touch on some of the exciting science coming. So through most of human history, you lived, you got sick, and you died basically all in one breath. And then we had the 20th century modern medicine. And what that means is, yes, we live lots longer, but a significant proportion of that for many people is with chronic disease. The future ideally would be that we again close the gap between health span and lifespan, how long we're healthy and how long we live. And do we live a little bit longer? Maybe. There are some ecological reasons why that might not be so good for our planet and for people generally, but certainly increasing the health span makes good sense. And there are geroscientists doing this, looking at therapies that where a single molecule might, rather than fixing your cancer or fixing your heart disease, prevent you from getting or slow down the progression of both simultaneously. Very exciting stuff. But in the meantime, we actually know a lot of how to do that. There is this thing called exercise, which you may be tired of hearing about, but it is hands down the single best medicine we have. It treats insomnia, depression, anxiety, Parkinson's, Alzheimer's, many cancers, heart disease, high blood pressure, diabetes, and I could go on. So think about what you can do and what we can do as a society to support healthy aging. Currently in the healthcare system, I think that's a misnomer. What we have is a medical care system. We want you to do usual aging, and then health systems are paid quite well for you to get sick and for them to treat you. What they're not doing is helping you stay healthy. Although some, like at UCSF, I now have a clinic that enables me to do this, but it's the exception, not the rule. What can you do? Well, it turns out people who have positive attitudes about aging get heart disease 7.5 years later. Their brain has less shrinkage in the hippocampus, the memory center. They recover better from disability and illnesses. This is the work of Becca Levy at Yale. So positive attitude about aging, being able to use those words about old age and apply them to yourself with pride, or at least without any negativity, will make a difference. So this is from the New York Times, Talk to Me, Not My Daughter, and it shows the old woman pictured as small. Now, we do all shrink with age, but there's a lot of infantilizing of older people, of speaking to people in baby voices. Are there some analogies between being a child and being an older adult? Yes, there are some. But it's not about going full circle. It's about going forward. And there are a lot of similarities, actually more between adulthood and elderhood than between childhood and elderhood. These are distinct life phases. Nobody should ever be infantilized, and they should always be spoken to directly. So this is a common picture of the human lifespan. You see that there are 4 categories for children: a neonate, or infant, a toddler, a child, and a teen. Then we have 4 categories for adults, starting with a young adult, moving through, young parent to adult to middle-aged person. And then there's a single category for old age, and that person is in a wheelchair. I would argue that we're missing a huge part of that picture, that old age has at least as many stages as other phases of life, and we need to start talking about them, labeling them, and discussing them. So I am not quite at this last adult phase, though moving rapidly towards it. My mother, 30 years my senior, is not in a wheelchair. This does not capture our family's experience, nor does it capture most families' experience. So what if the greatest limitations of aging come from our imaginations and policies, not our physiology? And with that, I will stop, and I'd be happy to answer any questions. Thanks for your attention.
Oh, thanks so much, Louise. I love this topic so much. It gets me excited to hear you talk about these really inspirational. And we do have lots of questions, so let's get at them.
Okay, all right.
One that came in, a couple came in advance, so I will share those from Patrick Collinane, who said, to achieve public policy change on aging in our country, we need champions at the state and federal level. And you touched on some of those issues. He's wondering if you see who are effective champions that we can rally behind in particular.
Oh, such a tough question. Joanne Lynn at Alterum is great. Mike Wasserman has been out in front of these are both geriatricians, unfortunately. Ashton Applewhite is not a geriatrician, but advocates. Sometimes people get put into positions and they don't know much about aging, but Kim McCoy-Wade in California Department of Aging has really made herself into an expert. I think as, you know, in my field generally, there are not enough people, but there are lots and lots of experts. And those people need to participate in the levels of policy and government. And policies and governments need to know they want and need those people. And that means no matter who you are, you need to start making noise, saying, I notice you have a whole section for kids. Or sometimes they'll say, we do have a section for older adults, but what you'll notice is the people in the section for adults and kids studied those fields, right? That's what their degrees are in. And the people who are dealing with the older people, unlike Carrie, who actually does have a gerontology degree, don't have that training. So we need more people like you, frankly, at all levels. And people, you know, if you need an encore career, do gerontology, get in there and make a difference, right? We're living decades longer. That is a time we can all make change.
Absolutely, hear, hear. Here's a question about finding a geriatrician. And this person, Nancy, in her 70s, wants to find one, but they're far and few between. And mostly are very young doctors available. So what advice do you give someone to try to find at least someone in geriatrics, maybe even a doctor or otherwise?
Yeah, so they're nowhere near enough. You know, kids, if you look at just hospitalizations, because we have better data on that, 6% of hospitalizations are children. Depending on where you look, it's 35 to 55 or 60% are older adults, and the remainder are adults. So we have something like 90,000 pediatricians and hundreds of thousands of adult doctors and about 7,000 geriatricians, and that's why you can't find one. One thing I think won't make a difference immediately, but ask your health system why they have specialists in the care of adults and kids and not in the care of you if you're an older person, or your parent if you're not. The more they see the demand, the more they will respond. And most health systems work with people who are training. We can create incentives to make this happen. Right now, it's literally disincentivized, not just because of social prejudice, but because of debt and salaries and stuff like that. But social prejudice matters because actually pediatricians make less than geriatricians, and people still go into that. So make noise. In the meantime, what can you do? Ask around. The American Geriatric Society has a search engine. It's not perfect, but you can call them and ask. What you may need to do is go somewhere, maybe an academic center, and have a consultation or few, and then bring that back to your internist, because there just aren't enough people to do primary care geriatrics. But that would at least enable you to see someone, say, once a year, and provide some advice to you and to your primary clinicians.
Oh, great. Donna Shemp, nice to see you or hear you there, has asked, how much of death of older people in SNFs or skilled nursing facilities was also about the residents there were sicker and poorer than other situations? And I'm assuming she's talking about during COVID.
COVID. Yeah, so COVID deaths, depending on the state, are anywhere, you know, it's for skilled nursing, it's anywhere from about 30% of deaths to about 80%. So that tells you a few things. It tells you it's not just about being old and frail, because people are old and frail pretty much equally in all different states. So on the low end, you have New York, where most of the deaths happened in the spring, but they literally weren't counting them because they were so overwhelmed by the surge. And in fact, Governor Cuomo was sending people with COVID back into nursing homes, bringing the virus and causing the outbreaks and deaths. And the federal government forgave, like nobody has to report deaths through May, and lots of places don't report deaths. There's also a huge influence of racism here. So the more African Americans in a facility, the more likely death. Now, some people will come back at that and say that's about health insurance or underlying diseases. These studies are corrected for income, for health insurance type, for any kind of underlying disease that causes, right? This is structural racism. Also, the healthcare system was providing PPE to healthcare facilities, but not to skilled nursing facilities. They were providing testing daily to people in the NFL, to people in the Trump administration who, with their super spreader events, daily testing. but it was really hard for people in those facilities to get testing. So yes, you're more vulnerable if you're old and frail, but a huge percentage of these deaths were due to absolute neglect and inequities in distributing the things that we know keep people safe.
Yeah. Another question from Donna. This is interesting. How did we get MDs to stop saying, quote unquote, at your age when explaining your medical problem? And I know there was Ashton Applewhite had made this recommendation that we take age off of someone's chart when they come into an appointment to see if the diagnosis would be treated differently. So can you say a little bit about that with providers?
Yeah, it's interesting. I tend to think of it as, we know, I personally believe age isn't a disease, but age does increase your risk for a variety of diseases and your vulnerability to both diseases and the treatments, right? Because we have this thing called Physiologic Reserve, which changes over our lifespan and brings us closer to that borderline between function and dysfunction, which means a couple of things, which means if this is the line of dysfunction, you live closer, the same small decline that might make it so, say you're a young person with a cold, a really, really, really bad cold, you might run up the steps and think, my gosh, I can't breathe, and normally I'm a runner. If you're an older person with a really, really bad cold, you might actually need to go to the hospital for oxygen. But the other part of that story, this is why it's all about which story you tell, is that often a little bit of oxygen or a little bit of fluids, and you actually take the person back from looking pretty ill and pretty disabled to being fully functional. And that's where this age thing is a problem. If people write it off as age, oh, there's nothing we can do about it, as opposed to age is a factor. This is why I think about elders differently than how I think about adults, and why I'm going to do this for this person to make them better. Then we end up with a better health system. But when people use age as an excuse for not making a diagnosis, that's unacceptable. And I think you should call them on it. You should say, my understanding is age isn't a diagnosis. I understand it puts me at higher risk, but just like a younger person, I'd like to know what's happening with my knee or my heart or whatever else. And I'd like you to help me with that. And if you can't, I'd like you to refer me to someone else who will. You can say that politely.
Yeah, exactly. There's a couple of different questions about the language. I think we could all sit around and talk about it a lot about it. So maybe you could give remind us of a framework to think about with what we call people that are older. So, can you explain a little bit again about the language? What should we call older adults? I missed that. Also, what label do you prefer? So you could speak to that.
Okay. Yeah, I sort of love that question. I'll sometimes give the whole talk and people will be, that's fine, but I'm not going to use any of that for myself. I literally think we will always live in an ageist society until you can say I'm old. And I actually started practicing. I'm technically still middle-aged, although, not aging as well as Carrie, clearly. But anyway, so my students are in their 20s, so I call myself old now because to them, they can't tell the difference. And it's fine, and what also it teaches them not to say, oh, you're not old. I've got my gray hair, I've got my wrinkles. I'm of course old to them. They think I'm old. I would have thought I was old at their age. I did think, people like me were old. So it's fine. There's nothing wrong with it. You get used to it. It's a little awkward at first. But technically, senior and junior, we use those for, say, college students, right? We use it for people with the same name. It means one came before the other. Nothing wrong with it. Old just means you've lived longer. True statement of fact, sort of like young, you haven't lived as long. Right? These are equivalent. There's no moral anything. It's just a term with a definition. I actually opened my book talking about an exercise somebody at UC Berkeley used to do where he would put the word old up and have people respond in a minute. And they would just say all these negative things, wrinkled, bent over, feeble, etc. And then he'd put the word elder up and they'd say wise, powerful, respect, all these good things. And the definitions of those two words are identical when applied to a human being. So the words are not the problem. It's the prejudice we carry with it. And look at who's leading our government. Until people like that can say, this is what old looks like. And old also looks like the person in a nursing home who, just because they are less fortunate than I, does not mean they should be written off. The more the people in what's called the third age of old age, that the more functional stage, distance themselves from the fourth age, the more we all create a world in which when we get there, we will be treated without compassion, without resources, without the humanity that everyone craves at every stage of life. So we just have to start. There's nothing wrong. Like, the terms are the same, they're fine. In my book, I argue for a progression, kind of like we have for childhood and adulthood. Doesn't mean I'm right. Maybe we need new terms. But until we start using them in the neutral ways that they were designed for, we will live in an ageist society, and we will all be harmed by that society.
Thank you. There are questions about the lack of geriatric training in medical school. How do we lobby or help increase that when there really don't seem to be a lot of geriatric education programs available?
Keep making noise. If health systems see that the people they take care of, they want to subscribe, want geriatricians, they will demand it from the medical schools. And the medical schools will, or even people with more expertise, the medical schools will need to respond in turn, create social impetus. We're actually starting to see more young people asking about this and interested in this, and it's because they hear and read about old age. Talk about all the ways. I mean, actually, when you think about cutting edge of science, geroscience is right there. When you think about tech, and this pandemic has really shown us, like, what's a huge untapped market where they could do better? Old age. When you think about clothing design, when you think about home design, the opportunities here are huge, and we tend to talk about these things as negative. Spin it more positively. Talk about all the things that, old people have to offer and that need, and how that helps all of society, right? We're in an economic downturn. This is an opportunity to build differently and better. But for old age training, until people see what they don't know, they're not going to demand it. So I really think it's sort of a supply and demand thing, and just be demanding constantly. Do it politely, because otherwise they'll just write you off as that annoying, crazy person. So do it politely, but show the inequity and just say, I'm not asking for anything special. I'm just asking for the same, please.
That's right. We do have a hand up. Let's see, I think we have a question from a phone call, and I'm just going to try to see if they can talk. I've not been successful at this in the past. So 214-243-9207. You had your hand raised, I believe, but do you have a question? Can you talk? I'm not always successful with unmuting phone lines, so I'll leave it unmuted. You're welcome to speak up and talk over me, or Louise if necessary. I want to wrap up with one general theme that comes through several of the questions, and we didn't get to all of them. There's 27 more questions here. Very, very engaged.
When there's chat also, I think there's more.
I don't know if we can. Lots of compliments, lots of feedback. But there's the insidiousness of ageism in all of our systems. And I guess just driving home how we can, even when I listen to some of the talk radio shows on NPR, some of the more popular ones, the last joke that seems to be acceptable are ones about age. Leave out everything else, but it seems like that. So, and it's so acceptable. So what do we do to help raise the bar and awareness that people, even if they don't realize they're doing, they mean well, they mean the best, and they are, ageist at heart per se, but you can, in their actions.
All ageist. We're all ageist. It's the culture in which you're raised. So I should have said this and didn't mean to say it. Like, this doesn't mean you're a bad person. Part of why I was able to write the book was I got into my 50s and I started making these comments too. And I was like, oh my gosh, I have devoted my whole adult life to this. And I'm saying all these things everybody says. Like, I was just appalled at myself. And so I've retrained myself, and still sometimes it happens, right? We're all human. So acknowledge that. But I think one of the things I like to do is say, I can see that's funny. And I also can totally see that you didn't mean any harm. And what I'd like you to do is sort of see who it is. Sometimes it helps to say, what would happen if you substituted in that joke for old, Jewish, female, Black, Native American, gay, something, some other category. And it usually leads to a pause and some reflection. Why is one thing okay and the other isn't?
Yeah.
Exactly. It's just asking not to be treated differently. It's equity. Equity as opposed to equality. Equality is, well, actually I should be clear because I said not to be treated differently. So you need to be treated differently because you're old. So it's that equality means everybody gets the same thing. Equity means everybody gets what they need. And what we need more in this society is equity. Because what you need when you're 85 is different from what you need at 45, is different from what you need at 15.
Yeah, exactly. This has been so much fun and so enjoyable and re-inspiring, Louise. I really want to thank you for waking us up all today and getting us to think more about this, what we can do ourselves, and become more aware. There's your book, Elderhood, which I said comes out in paperback next week. A wonderful insight and sort of an instruction manual for understanding these sorts of things that we've been talking about today. And I know we didn't get to all the questions, but I really want to thank you and for answering many of them, and everybody for joining in today on this important talk. So I want, if you'd like to stay tuned, please, to learn more about Belmont Village, Jackie Wahlberger will be speaking more about their programs, which I find very innovative and they are very evidence-based. But Louise, we can all give you a hand clap and say thank you. You're welcome to stay on, but if you need to move on to your busy life, we understand that too. So thank you so much.
I have a meeting. Yes, I have a meeting in 1 minute, but thank you all. This was a great group and a real pleasure.
Thank you, Louise.
Yeah, thanks so much. Thanks
Bye.
again. Bye-bye.
Thank you, Carrie. Thank you, everyone. My goodness, that was wonderful. And I just want to reiterate, I actually have Dr. Aronson's book in hardcover. It is available, and it is also available in Audible, which I love. So thank you so much for joining us today. I'm Jackie Waldberger, and I have personally assisted thousands of people who have made the transition in moving from home to senior living in search of a more healthy and social lifestyle. I've been in the middle of many family dynamics and stories, and everyone is different. I can confidently tell you that on the other side of that leap of faith, there are so many opportunities. For 24 years, Belmont Village has developed, owned, and operated best-in-class, fully licensed senior housing and care communities. What makes Belmont Village different? Unlike continuing care retirement communities, we do not require a large upfront investment, nor does a resident have to be independent to start at Belmont Village. A resident can join us in independent living, offered at some communities, assisted living, or either of our 2 levels of memory care, because not one size fits all. Unlike the CCRCs, our residents do not have to move to skilled nursing simply because they need a high level of care. Our nurses are on site 24 hours a day, and our residents can receive care in the privacy of their own apartments or physical therapy at our on-site center, all the while enjoying extraordinary hospitality and vibrant social engagements. In alignment with the purpose of a village, our focus is bringing people together, providing choices and opportunities, safety and security, and an overall better quality of life. To talk about the Belmont Village difference, we must begin with our thorough approach to health and wellness. By having nurses in the building 24 hours a day, we can establish a high level of trust and security. Our nurses are able to provide on-site care and triage with our residents' personal physicians. If we are unable to reach our resident's physician, we contract with telemedicine doctors available around the clock that can be called upon anytime for their expertise. Having physical and occupational therapy on site is so convenient for our residents to stay motivated with their program. We've helped so many people get back on their feet. The Personal Assistant Liaison, or PAL, is available to assist our residents at any time. A schedule of preferences can be made ahead of time, or they can be called upon by wearing a pendant sensitive to the location of our resident anywhere in the building. Our residents also have the added security that each one of our visitors has to check in through a kiosk. Not only can we account for who's been in the building at any time, our kiosk is tied to a national database for criminal background checks. In the current climate, we have gone above and beyond with COVID-19 testing capabilities. We are continuously testing our employees and residents to look out for those asymptomatic cases. Importantly, we have also the resources to test our visitors so that we can keep our families united. Further, our communities have been privileged to be among the first to receive both rounds of the COVID-19 vaccination. We are so excited about what that means for our future. We take the whole person approach in providing service. First is the foundation of safety and well-being, and then we can focus on engagement, making new friends, fulfillment, and enjoying ourselves. In conjunction with our passion for safety is our passion for hospitality. The Belmont Village Way is to provide choices. Modeled after the Hilton School of Hospitality, we offer dozens of dining options developed by world-class chefs and nutritionists. Our hair and nail salon offers a wide menu of services, keeping our residents looking and feeling their best. And we provide complimentary transportation anywhere our residents would like to go, 7 days per week. In consistency with choices in hospitality comes choices in things to do. Take a glance at our calendar. There's so much to do here, and our residents can count on punctuality. Our residents are able to plan ahead and arrange their schedule to be sure they don't miss their favorite class. We pride ourselves in offering a variety of classes led by professionals. Each location takes on a culture of its own as the activities are resident driven. Here we see examples of yoga, meditation, and Tai Chi. Whether our residents want to kickstart the day with group fitness or one-on-one exercise, they are in good hands. Develop artistic skills and join an art show. Many residents that don't join other activities join art classes regularly. There is something for everyone. The Belmont Village Difference celebrates cultural diversity. We see here festivities for Dia de los Muertos or Diwali. Staying intellectually stimulated is important to us. Here you see examples of our book club or current events discussion group. Perhaps you are more of a film buff or opera lover. Or maybe you are up for an adventure. Our excursions are designed with seniors and safety in mind. We always take plenty of staff and even an extra wheelchair in case someone gets tired. And for those who stay back, we offer a wide variety of on-site musical performances. We have students come in for intergenerational activities, and of course, our highly attended lectures, once offered only in-house, but now widely available to the general public. What about our residents that need a little more attention due to short-term memory loss? The Circle of Friends is an award-winning and evidence-based program for residents with mild cognitive impairment. It is a small club within our assisted living that benefits from all of our robust programs, in addition to specific therapeutic programming. In principle, in order to maintain a healthy brain, we should introduce new concepts and a mental stretch to our daily lives. The Circle of Friends is designed to improve whole brain fitness by encouraging the right nutrition, physical exercise, proper medication management, mental workouts, developing a strong social network, and a newfound sense of purpose. This group really opens up a whole new world. Life is not always about fun and games, although there is a time for that. Our residents in our secured memory care are given the satisfaction of exercising their potential to their fullest extent. I witnessed this amazing transition for residents who initially did not want to engage, slowly find that not only are they capable of engaging, but also enjoying themselves. Disguised as fun, we target critical thinking, learning new things, long-term memory recollection, and analytical solving. I am particularly amazed at the memory body movement. Can you see that picture at the top center? With time, all of our residents in memory care are able to follow routine, develop self-esteem, and a feeling of social belonging. Our innovative programs could not have been designed without the long-standing tradition of collaborating with brilliant minds and academic institutions to help advance the field of gerontology. Our own Vice President of Programming, Beverly Sanborn, is a graduate of UC Berkeley and UCLA in social work and gerontology. All together, we have changed the paradigm in senior living and continuously redefine aging. Take a look at our beautiful buildings. This is not senior living, this is living. Built with institutional grade construction, we have the highest quality and safety features. Here in California, we especially appreciate the protection against fires, earthquakes, and rolling blackouts. At Belmont Village, we like to keep the lights on. Look at these gorgeous spaces. Our buildings have won awards for design and architecture. And the results of doing the right thing show. Being a purpose-built community, we have set new standards in resident satisfaction. Take a look at this industry survey. In comparison to Belmont Village, the industry scores in resident satisfaction, loyalty, and healthcare needs 80 to 83%, while Belmont Village scores closer to 94%. Meal enjoyment is notoriously hard to please. Belmont Village scores a whopping 25% ahead of industry standards. And we cannot be a great place to live without being a great place to work. Belmont Village is ranked in Fortune's best places to work in aging services. Today, we boast more than 4,000 employees nationwide. And I'd like you to meet the woman behind it all. Many of you met her at the beginning of the call. The founder and CEO of Belmont Village, Patricia Will, who built our communities as the kind of place we would choose for our families and ourselves. In 1997, Patricia opened the first Belmont Village in Houston. Here she is joined by her two sons in the ribbon cutting ceremony. And to the right is a picture of her mother-in-law, Josephine Will, who helped inspire the creation of Belmont Village when she was diagnosed with memory loss in 1994. Patricia's return on investment has been priceless, as her purpose-built communities have been called home by each of her parents. You see here to the left, we see Patricia with her father, Ed Will. In the center, Patricia's parents, Laurino and Jacqueline, with their first great-granddaughter. And to the right, Patricia's mother at 92 with her great-granddaughter. Today, Belmont Village has grown into a national provider, not striving to be the biggest, but the best. 32 best-in-class operating communities in 7 states and Mexico City, all built, operated, and owned by Belmont Village. That concludes our presentation. Thank you so much for your time today. I hope you've enjoyed learning more about our extraordinary approach to senior living. If you have more questions about a Belmont Village near you, I encourage you to visit our website, belmontvillage.com, or call our family advisor, Jamie Danili, at 844-706-CARE. That's 844-706-2273. Have a wonderful day, everyone. We look forward to seeing you at our next event.